Hello, I will be presenting ultrasound of the uterus. Ultrasound is a technique utilized for gynecological assessment. Grayscale ultrasound allows us to visualize female pelvic organs. Color and spectral Doppler enables us to assess normal and pathologic blood flow and distinguish vascular from non-vascular structures. By instilling saline into the uterine cavity, sonohysterography provides a detailed image of the endometrium and allows differentiation of intracavitary, endometrial, and submucosal lesions. The objectives of pelvic ultrasound are to recognize common causes of pelvic pain and abnormal vaginal bleeding, identify uterine structure, correlate the endometrial appearance to the time of the menstrual cycle, and define sonographic characteristics of an adnexal mass. A patient will often present with one or more of the clinical symptoms, including pelvic pain, palpable mass, or abnormal vaginal bleeding. The diagnostic workup includes a detailed clinical history, physical examination, laboratory data, and imaging, utilizing ultrasound as the first imaging modality. We want to answer the question, where is the pathology? Is it adnexal? Is it uterine? Or is it related to other structures, including the bowel, the GU tract, lymph nodes, or vessels? This is a diagram of the female gynecologic tract depicting the uterus, fallopian tubes, ovaries, endometrium, cervix, and vagina. There are three sonographic approaches to visualizing the uterus. Transabdominal ultrasound utilizes a distended urinary bladder as an acoustic window to visualize the uterus and ovaries. With transvaginal ultrasound, a transducer is placed in the vagina, the bladder is empty, and the organs are brought closer to the focal zone of the transducer. In saline infusion sonohysterography, saline is instilled into the endometrial cavity via a catheter while performing simultaneous transvaginal scanning, allowing exquisite visualization of the endometrial cavity. This is a picture demonstrating the transabdominal approach to pelvic ultrasound, utilizing the urinary bladder as an acoustic window. This is a picture demonstrating the transvaginal approach to pelvic ultrasound. The uterus lies in the true pelvis between the urinary bladder anteriorly and the rectosigmoid posteriorly. However, uterine position can change with varying degrees of bladder and rectal distension. The cervix remains fixed in the midline, but the body is mobile. We use the term flexion when referring to the axis of the uterine body relative to the cervix. We use the term version when referring to the axis of the cervix relative to the vagina. The uterus varies in size and shape throughout life and is related to age, hormonal status, and parity. The endometrium is composed of the deep basal layer, which remains intact throughout the menstrual cycle. This layer contains the spiral arteries, which elongate to supply the functional layer of the endometrium. The superficial functional layer thickens throughout the menstrual cycle and is shed with each menses. The myometrium is composed of three layers. The inner layer is hypoechoic and is known as the subendometrial halo. The intermediate layer is the thickest layer and has a uniform homogeneous echotexture. The outer layer is slightly less echogenic and is separated from the intermediate layer by arcuate vessels. The premenopausal endometrium cycles through phases. In the menstrual phase, it is a thin, broken echogenic line. In the proliferative phase, it begins to thicken and is influenced by estrogen. Often, it has a trilaminar appearance. The endometrium becomes thickest in the secretory phase, just prior to menstruation, with a uniform hyperechoic appearance and is influenced by progesterone. Transabdominal images depict the uterus in the long and transverse axis, and we see the endometrium as an echogenic line. This is a transvaginal image of an anteverted uterus. The endometrium has a trilaminar appearance and measures 6 mm, corresponding to the proliferative phase. This is another patient. Transvaginal images demonstrate a retroverted uterus. The fundus is pointing caudad, and we see a trilaminar endometrium with a thickness of 8 mm, corresponding to the proliferative phase. The postmenopausal endometrium is thin and atrophic, measuring between 4 and 5 millimeter. This is a transvaginal image from a postmenopausal patient. The endometrium is thin and echogenic, measuring 2 millimeter. Let's discuss myometrial abnormalities. The leiomyoma, commonly known as a fibroid, is the most common neoplasm of the uterus. It occurs in 20 to 30% of females over the age of 30. It is more common in African American females. They are often multiple, and they are the most common cause of enlargement of the non-pregnant uterus. Fibroids can occur in different locations. The intramural location is most common. The submucosal location, when it projects into the endometrial cavity, is the most symptomatic, causing bleeding and pain. And the subserosal fibroid may mimic an adnexal mass as it projects outward from the peritoneal surface. Realize also that leiomyomas may encompass more than one location. This is a picture depicting different locations of fibroids. A fibroid may be strictly intracavitary or submucosal. It may be intramural and submucosal, projecting partially into the endometrial cavity. It may be strictly intramural, strictly subserosal, or a combination of locations. Pathologically, leiomyomas are a benign soft tissue tumor composed of smooth muscle cells arranged in a whorl-like pattern. They have a variable appearance sonographically and may be hypoechoic, echogenic, or heterogeneous in appearance. They may have calcifications, and they may have cystic spaces representing degeneration and necrosis. These are two transabdominal images demonstrating a markedly enlarged, heterogeneous, diffusely myomatous uterus. These are two transabdominal images demonstrating a large, rim-calcified intramural myoma. These are transvaginal images from a conventional ultrasound and additional images from a saline hysterosonogram demonstrating a large heterogeneous mass expanding the endometrial cavity, confirmed by saline ultrasound to be a submucosal leiomyoma. Transabdominal and transvaginal images of this patient demonstrate bridging vascularity to a subserosal pedunculated myoma. Transvaginal images in this patient demonstrate a subserosal pedunculated myoma with two focal hypoechoic regions representing cystic degeneration within the myoma. This is a photo from laparoscopy demonstrating multiple myomas. Lipomatous tumors are rare and comprise a spectrum including lipomas, lipoleiomyomas, and fibrolipomyomas. The appearance on ultrasound is of a bright echogenic mass. Here we have a transvaginal image of the uterus demonstrating a heterogeneous submucosal mass with a few extremely echogenic regions. Also note the small amount of fluid in the endometrial cavity outlining the mass. Axial and sagittal images from a correlative CT demonstrating a large uterine mass containing macroscopic fat consistent with a lipoleiomyoma. Leiomyosarcomas are rare and account for 1.3% of uterine malignancies. They may arise from a pre-existing leiomyoma, and the appearance is similar to a rapidly growing or degenerating myoma. This was an ultrasound performed on a patient who had suspected fibroids. Ultrasound demonstrates a markedly enlarged, heterogeneous myomatous uterus measuring 16 by 10 centimeters. CT and MR of the same patient demonstrate a markedly enlarged, heterogeneous mass occupying and expanding the uterus. It is complex cystic and solid. It contains calcifications with multiple areas of low attenuation consistent with necrosis, and this was a pathologically confirmed leiomyosarcoma. Adenomyosis is defined as the presence of endometrial glands within the myometrium. In the diffuse form, there are widely scattered foci of adenomyosis within the myometrium. In the nodular form, a well-circumscribed nodule is seen and called an adenomyoma. Sonographically, adenomyosis presents as diffuse uterine enlargement, often with preferential thickening of the posterior myometrium. There are inhomogeneous hypoechoic areas in the myometrium, and small myometrial cysts may be seen. Transvaginal images demonstrate a globular appearance of the uterus and vertical linear striations representing the Venetian blind appearance seen due to interspersed heterotopic endometrial tissue with hypoechoic myometrium. On MRI, ectopic endometrial glands and stroma are present throughout the myometrium, and a thickened junctional zone is present measuring greater than 12 millimeter. Coronal and axial MR images demonstrate punctate T2 bright foci scattered throughout the myometrium and a markedly thickened junctional zone. An AV malformation consists of a vascular plexus of arteries and veins without an intervening capillary network and may be congenital or acquired. This is a patient who underwent multiple prior DNCs, and ultrasound demonstrated a markedly vascular structure with extreme high velocity, low resistance, turbulent flow consistent with an acquired AVM due to prior procedures. Angiography was performed demonstrating an AV malformation, and patient underwent embolization. Moving on to the endometrium. The differential diagnosis of endometrial thickening includes many entities, including those related to pregnancy, infection, and also endometrial polyps, hyperplasia, and carcinoma. Abnormalities of the endometrium include polyps, hyperplasia, and carcinoma. Endometrial polyps are a common cause of vaginal bleeding. They are localized overgrowths of endometrial tissue covered by epithelium. There may be multiple polyps, and on ultrasound they are seen as round, homogeneously echogenic masses within the endometrial cavity. These are two images from a transvaginal ultrasound on the left by two images on the right from a saline hysterosonogram demonstrating a smooth, round, echogenic mass within the endometrial cavity consistent with an endometrial polyp. Endometrial hyperplasia is the proliferation of glands of irregular shape and size, and there may or may not be cellular atypia. Transvaginal ultrasound in a postmenopausal woman demonstrates endometrial thickening measuring 18 millimeter, confirmed to be endometrial hyperplasia. Endometrial carcinoma is the most common gynecologic malignancy in North America. The most common symptom is uterine bleeding, and it most often occurs in postmenopausal women. On ultrasound, the endometrium is thickened, often with a heterogeneous echotexture and poorly defined margin. These are transvaginal images from two separate patients who each presented with postmenopausal bleeding. Ultrasound demonstrates endometrial thickening up to 10 millimeters. Cystic spaces were seen in each. These were each confirmed to be endometrial carcinoma. The breast cancer agent tamoxifen has a weak estrogenic effect on the endometrium and may lead to an increased prevalence of polyps, hyperplasia, and carcinoma in patients being treated with tamoxifen. These are two separate patients. The top left patient has a thickened heterogeneous endometrium with a few tiny cysts and had tamoxifen-associated endometrial hyperplasia. This necessitated stopping tamoxifen medication. The bottom right patient had a markedly thickened endometrium with tiny cystic areas and had developed a tamoxifen polyp. The polyp was removed and patient was able to continue with tamoxifen treatment. Hydroculpus and or hematometrioculpus may be an indication of mechanical obstruction. This is a 12-year-old female who presented with abdominal pain. Transabdominal ultrasound demonstrates a distended vagina filled with complex fluid and diffuse low-level echoes. A small uterus is seen superiorly. This is consistent with hematoculpus due to an imperforate hymen. Transvaginal images from a 35-year-old female demonstrates marked distension of the endometrial cavity with complex fluid containing low-level echoes consistent with hematometria from cervical intraepithelial neoplasia. Endometritis may occur postpartum following DNC or associated with pelvic inflammatory disease. The endometrium can appear thick and irregular, and there may be fluid and or gas within the endometrial cavity. These are two transvaginal images from a patient who is 7 days postpartum with an elevated white count and fever. Multiple echogenic foci producing dirty shadowing are seen within the endometrial cavity consistent with gas, representing endometritis. Uterine artery embolization may lead to tissue infarction. This patient is status post uterine artery embolization, and there is infarction of the leiomyoma, and multiple small bubbles of nitrogen are present due to the infarction, seen as tiny echogenic foci with dirty shadowing. Endometrial synechia may be a cause of infertility, but only become apparent if fluid outlines the endometrial cavity. Saline infusion sonohystogram demonstrates multiple adhesions extending from the anterior to the posterior wall of the endometrial cavity, consistent with uterine synechia. Saline infusion sonohystogram in a second patient with infertility demonstrates an irregular endometrial cavity on the two-dimensional image, suggestive for adhesions. Three-dimensional image demonstrates a uterine band traversing the endometrial cavity within the mid to lower portion of the endometrial cavity, consistent with a synechia. IUDs are used as a reversible form of contraception. They appear as echogenic linear structures, but in patients presenting with pelvic pain, abnormal bleeding, or missing strings, ultrasound is performed to assess position. An IUD may be malpositioned, migrated, embedded, or perforated. Transabdominal and transvaginal images in this patient demonstrate a malpositioned IUD in the lower uterine segment. This next case is from a patient who presents for evaluation of an IUD. The top two images demonstrate normal IUD position. The bottom images were performed 3 weeks later when patient returned with complaints of pelvic pain. Note that the IUD has migrated inferiorly and is now malpositioned in the lower uterine segment. This transvaginal ultrasound was performed in a patient in whom the IUD string was not visualized. The IUD was not visualized in the endometrial cavity. The upper left image demonstrates an echogenic focus seen between the left ovary and the uterus. The right-sided image was performed to evaluate the echogenic focus. By rotating 90 degrees and scanning the adnexal region, a linear echogenic structure representing the IUD is seen extending from the uterine serosa into the left parametrium. This IUD had perforated through the left uterine wall. Congenital uterine anomalies occur in approximately 0.5% of females and are associated with an increased incidence of spontaneous AB and additional obstetric complications. There is also a high association with congenital renal anomalies. The two paired Mullerian ducts develop into the female reproductive tract, which includes the fallopian tubes, the uterus, cervix, and upper 2/3 of the vagina. Uterine malformations can occur due to arrested development of the ducts, failure of fusion of the ducts, and failure of resorption of the median septum. Failure of fusion can lead to uterus didelphys, bicornuate uterus, and the arcuate uterus. Failure of resorption of the median septum can be complete or incomplete, leading to septate or subseptate uterus. These are pictures demonstrating a normal uterus on top, abnormalities due to failure of fusion, and abnormalities due to failure of resorption. This is an image, a three-dimensional ultrasound image from a saline study demonstrating a fundal cleft measuring less than 1 centimeter, a convex uterine contour on this coronal image consistent with an arcuate uterus. This was a patient who presented with a history of recurrent fetal loss. 2D ultrasound image on the left-hand side demonstrates 2 endometrial cavities. 3D image on the right-hand side demonstrates a convex fundal contour with complete separation of 2 endometrial cavities, consistent with a complete septate uterus. Touching briefly on the cervix. The cervix is difficult to assess transabdominally. It is best seen transvaginally. We evaluate cervical length when we perform obstetrical ultrasound exams. We consider a normal cervical length to be 3 centimeters or longer. This is a patient on transvaginal imaging. The cervix is demonstrated to measure 3.3 cm. This was a transvaginal image in a pregnant patient demonstrating cervical shortening measuring 2 cm and cervical funneling measuring 1.6 cm in diameter. These are signs of cervical incompetence. So to summarize, I presented an overview of ultrasound of the uterus with occasional correlative imaging, both the normal appearance and pathology of both endometrium and myometrium. Thank you.